All right, thank you. Before I get started, I just want to take a second to acknowledge my co-author, Catherine Yaramata, who's in the audience today. So my talk is going to focus on weighting and combination methods we use to combine estimates from two probability-based online panel surveys as part of the new National Center for Health Statistics Rapid Surveys system. I'm also going to present on a comparison that we did of the first round of RAPIDS estimates to estimates from the National Health Interview Survey. There we go. So as noted, RAPIDS is a platform that's utilizing two commercial probability-based panel surveys. As you can see here, they're NORC's Amerispeak panel and Ipsos's Knowledge panel. We're using these panels to collect data to produce timely and relevant estimates on emerging health topics. Right now, we're collecting data on a quarterly basis, with each round of data collection followed by a release of public use and restricted access data. We have web tables and dashboards of estimates that we're releasing, documentation, and each round comes with a quality profile. And I should note that the first round of data is out there. We released that data back on February 21st, so I encourage you to go check that out. Now, the first round of RAPIDS went into the field in August. It included questions on topics such as air cleaners and purifiers, genetic tests, long COVID, and other. Each of the panel providers performed two data collections. The first, which we refer to as Method 1, would just use their standard data collection procedures. The second, we refer to as Method 2 and used enhanced procedures. And these included things such as additional email reminders to panelists, phone prompts to participate, and included additional telephone interviewing. The goal here was to try to boost participation, especially among hard-to-reach panelists, right? So we wanted to know, will this improve sample representation, for example? Now, the estimates and the data that were released with round one were from the Method 1 collection, so that's what I'm going to focus on today. Okay. So using that standard data collection procedures, you can see we collected about 7,600 completed interviews for round one. You can see the sample sizes, the completed interviews, and the completion breakouts here for each of the providers. All right, so what I want to do now is talk a little bit about the weighting and the combination methods that we actually use to produce point and variance estimates for the first round of RAPIDS. So at the end of data collection, each of the panel providers produced a final study weight using their normal procedures. So this included their standard set of non-response and or post-stratification adjustments, for example. Now, while the mix of variables are slightly different, both providers will rate their weights with one or two exceptions to the most current population survey March ASEC supplement, or totals from that supplement. Now, the two sets of panel provider weights were then separately calibrated to control totals based on the 2023 Q1 National Health Interview Survey early release data file for adults. And that calibration, as you can see here, was performed in PROC weight adjust in Sudan. And on this slide, we're showing you the list of variables that were used in that weight calibration step. So we had a total of 12 variables producing 32 control totals. You can see here, in addition to the kind of standard sociodemographic measures that you would see, we also included questions on things like ever diagnosed with high cholesterol, difficulty participating in social activities, and a measure of civic engagement, which were added to the round one questionnaire specifically for calibration to NHIS totals. And this was because their potential for reducing coverage and non-response bias have been highlighted in the larger literature, but were also recommended to us by a special working group of the NCHS Board of Scientific Counselors. All right, so we have these calibrated weights. Then to create a composite calibrated weight, the calibrated weights of, say, panel provider 1 were multiplied by this overall adjustment factor. Then the weights for panel provider 2 were multiplied by 1 minus that adjustment factor. And that adjustment factor in this case was just simply the ratio of the effective sample sizes. Those adjustment factors came out to about 0.271 and 0.729, so slightly imbalanced. These weights can be used then to directly produce a combined mean and its linearized standard error using usual survey estimation, right? So we're treating the combined data as a single survey with calibrated weights, and then provided strata and PSUs are used for variance estimation. All right, so what I want to do with the rest of the talk is I just want to talk about some comparisons we did, a bias evaluation in which we were comparing estimates from RAPIDS to estimates from that Q1 2023 NHIS data. So for the evaluation, we had 43 health outcomes that could be compared to NHIS data that were included on that round one questionnaire, and they covered a wide variety of health domains. So we had chronic health conditions, we had mental health, we had self-rated health, we had healthcare access and utilization measures, et cetera. I mean, part of what we wanted to learn over these initial rounds of RAPIDS are what health estimates or what health domains do these panels measure well, which ones do they not measure well, right? So when looking at percentages, which accounted for the vast majority of the estimates, difference were evaluated using a measure of standardized bias that you see here on the screen. And we used cutoffs of 0.1, 0.3, and 0.5 to measure low, medium, high bias in the RAPIDS estimates relative to the NHIS. Now note that the results that I'm going to present over the next few slides are also covered in that quality profile that I mentioned that we released with the round one data. Purpose of that profile is to really provide an overall assessment of the quality of RAPIDS data, see where we did well, where we didn't. It's not designed to necessarily evaluate the performance of any individual panel provider. So in that light, when I discuss these results, I'm just going to refer to panel provider 1, panel provider 2. Come on, there we go. All right, so what this graph is showing you is the standardized bias of panel provider estimates based on their panel study weights. Okay, so those are the blue dots here on the slide. And then the weights further calibrated to NHIS control total. So we go through that additional weight calibration step. Those are the red dots on the slide. And again, we're comparing to NHIS estimates from Q1 of 2023. Now this type of assessment allows us to evaluate the performance of that calibration weighting for each of the individual panel providers and to possibly inform changes we need to make to weighting procedures in future rounds. Now for readability, and I know this is still difficult to follow, this is showing you 25 of the 43 health outcomes on the screen, but I'm going to summarize the full set of results. So what we found is for panel provider 1, for example, 30 of the 43 benchmark variables had lower standardized bias when we used the weight calibrated to NHIS control totals. So when we did that additional calibration step, we saw a reduction in bias for 30 of those 43 items. That number is a bit lower for panel provider 2. It was 23 of the 43. You can also see the difference in the magnitude of the impact of that calibration weighting, right? We see bigger movements in the estimates for panel provider 1. For panel provider 2, in many cases, those dots are overlapping, telling us that when we did that additional calibration to the HIS totals, didn't really move the estimates. The other thing that I want to point out is we did have 7 estimates here across the two panels where we had an increase actually in bias, right? 5 of those were utilization variables. And in fact, if you look at the very bottom of the screen, you'll see an example of that, which is had your blood pressure checked in the past 12 months. Now this graph's presenting the standardized bias of the combined estimates now, right, compared to the NHIS. And again, we're showing the results for 25 of the 43 outcomes here, but I'll summarize the full set of findings. The standardized bias range from nearly 0 to 0.24 for the 43 measures that we looked at. 30 of those measures had standardized bias less than 0.1, which we would characterize as low bias. 13 had a standardized bias between 0.1 and 0.3, which we characterized as medium bias. And we had 0 that actually exceeded 0.3, therefore had high bias. But you can see, relatively speaking, there are some items that stand out on this graph out to the right-hand side. And again, these were things like self-rated health, some mental health measures, as well as some healthcare utilization measures. Finally, this graph just presents the standardized bias for the combined estimates by health domain. So here we're looking at average standardized bias. And what we're finding is things like chronic health conditions and health behaviors we do fairly well. The standardized bias on average for those items checked in under 0.05. But then if you contrast that, for example, again, with our self-rated health, mental health items, we had an average standardized bias of 0.14, and that was followed by healthcare utilization and access variables. All right, so I think this is just summarizing what I just told you. So I'm going to skip on for the sake of time to this last slide. And just, to remind people that the estimates that we're producing from RAPIDS are going to differ in quality from those that we produce with the NHIS or other household surveys. at NCHS. And with that in mind, we have kind of this robust research component with RAPIDS to really evaluate and clearly communicate what the fitness for purpose of these estimates are. And in that vein, we currently have a number of evaluations underway with round 1 and round 2 data, where we're thinking about, do we need to change up the mix of variables in the calibration weighting? Are there other combination methods that we need to consider for producing combined estimates from RAPIDS? What can we tell our sponsors about anticipated levels of bias, and what are we measuring well, what we're not measuring well? And so I'll just end now by just saying that the round 2 data collection is complete. The data are going to be coming out at the end of April, end of May. So again, I encourage you to go check out the website and see what's out there. Thank you.